Basic of biomechanics of the hip. Before you start using the app, you have to know some basics of biomechanics for a joint to function properly. It is essential that a balance be maintained between the stresses acting on the joint and the ability of the joint to withstand those stresses. If a disproportion exists, osteoarthritis will develop. This particularly applies to a weight-bearing joint such as the hip. In this case, the cause of osteoarthritis may be either extrinsic or intrinsic to the joint. Intrinsic causal factors may relate to the biologic quality of the articular structures. Extrinsic factors are due to joint concentrating loads in a localized too small area, as in hip dysplasia, where they result in premature osteoarthritis. The knowledge that is gained from biomechanical analysis and use for operative planning the app help to answer to certain question. If femur varus osteotomy alone or a combination of pelvic osteotomy is indicated, not. Load and pressure interplay are important to be measured before planning an operation. In the case of the hip, the load would be the vector sum of all forces transmitted from the acetabulum to the head of the femur. We call this vector sum. The resultant R. The magnitude of R depends on the body weight, the force of the muscles, tendons and ligaments that link the lower extremity with the trunk. Pressure on the hip joint is dependent by the magnitude and direction of the load R and on the size, shape, and relative positions of the femur and acetabulum. The area where hip and acetabulum are in contact and the load is exerted is the weight-bearing four of joint surface. The compressive stress, P, that acts on the articular surfaces of the femur and acetabulum is the result of load R exerted at the weight-bearing, FO. The smaller the weight-bearing area, the greater the pressure, and the larger that area, the lower the pressure. If the pressure exceeds the tolerance limit of the cartilage, degenerative changes will develop with the passage of time, and osteoarthritis is developed. The weight-bearing area is greatest with the horizontal head coverage. Here the compressive stresses are widely and evenly distributed, and their magnitude per unit area is small. With increasing steepness of the acetabulum, or with deficient anterior coverage, the stresses increase. There is a progressive lateral shifting of the resultant R toward the acetabular margin, as changes as the parameters T, Greek letter psi and D6 could be changed by an operation. The parameter T is a measure of the muscular lever arm H. Greek letter psi is a measure of the neck shaft angle. A change is associated with a change in the CCD angle, and D6 is a measure of the load arm. The load is decreased by an increase of T, a reduction of Greek letter psi, a combined increase of T and reduction of Greek letter psi, a reduction of D6, or by increasing the CE angle and shortening the distance y. The greater the value of y, the poorer the head coverage, and vice versa. Intertrochanteric osteotomies like rotational osteotomy, varus osteotomy, valgus osteotomy, or polyaxial osteotomy have a common goal. All these operations, besides relieving incongruity resulting from a non-spherical head or acetabulum, is to alter the muscular lever arm or force arm, H, with the object of changing the magnitude and direction of the load, by increasing the muscular lever arm H and thus the value of T, and removes pressure from the overloaded anterior or posterior regions of the femoral head and acetabulum. For the analysis of hip biomechanics, simple standard AP pelvic view is adequate. Geometric parameters of the hip that are necessary for a biomechanical analysis. The following reference points and geometric parameters, distances and angles, that are pertinent to a biomechanical analysis of the hip can be established from the AP pelvic film. Point C, center of the femoral head. Point E, side of insertion of the hip abductors on the greater trochanter. T, the exact distance from the center of the femoral head. C, to the side of muscular insertion. T, D6, perpendicular distance of the longitudinal body axis through center of gravity. S6, from the center of the femoral head. C, D5 equals 1.2. D6, Greek letter psi angle equals angle between extension of D6 and TCE angle between a line parallel to the longitudinal body axis through the femoral head. Center C, and a line from C to the superior acetabular rim. E, to get an accurate calculation of the hip resultant R, one has to know the exact distance from the center of the femoral head. C, to the side of muscular insertion. T, parameter T, because this distance is a measure of the lever arm H of the muscular force, the force arm. The resultant force R acting on the hip is given by the parallelogram of forces of the load G5 and the muscular force, and the line of action of G5 runs vertically through the partial center of gravity. S5 load determinations in the literature are based essentially on the load model developed by Pauwels in 1935. How to measure with the app. The first thing is to load one image from your photo library or capture a photo from X-rays photos of a patient. Next you fill in the empty boxes according the patient's height in cm and weight in kg, and at last the calibration unit box in mm. After finishing the calibration procedure, with the calibration procedure you try to locate the center of template, a known dimension in mm, object in X-ray, for example a coin, by moving the transparent circular yellow template over the object, coin, trying to fit to a best fit circle to the contour of the coin circumference. Once you have found the best fit by clicking the point button, the center of the coin is marked C1. Next a dynamic circle appears with a C1 center point marked over the screen. The radius of the circle is changed dynamically, and by moving the attached finger you try to find the best fit circle to the contour of the coin. Once you found the best fit you press the point button and the subject, whole coin, is marked by the circle R2. Point appears. If the coin for example is 10 mm you enter the number 10 in the box. Next by clicking the button point you mark 2 points, point S3, left, and point S4, right, over the lateral edge of the superior end plate of the S1 vertebra, sacral end plate. The yellow horizontal line S3 S4 is drawn. Next by aiming the center of upper middle distance of pubic symphysis with the transparent circular template and clicking the button point, the point S5 is marked. An erected vertical reference line from S5 is drawn. Right side, the transparent circular template appears and you aim to locate the center first of the right femoral head by moving the template over the femoral head, trying to fit to a best fit circle to the contour of femoral head circumference. By clicking the point button the center of the left femoral head is marked C6 point, and the corresponding radius of the femoral head by clicking the point button, R7 point, appears. Aiming with the transparent circular template to the lateral acetabular edge you mark the lateral acetabular edge. By pressing the point button, E8 point. Finally you aim with the transparent circular template the deepest point of the roof, the acetabulum or the triradiate cartilage if still open, usually at the halfway of the acetabular width, and by clicking the button point the A9 point is marked. A semicircle is printed. By the same manner you mark the V10 point, which is the lowest and most lateral point on the acetabular teardrop, and subsequently the point where the lower contour of the head intersects the postero-inferior acetabular margin. Point D11 is marked. Finally the site of insertion of the hip abductors on the greater trochanter, point T12, is also marked. Left side. Without to recalibrate you start the same procedure from the left side by marking the center of the left femoral head C13, R14, and as mentioned above with the same order you mark the rest of the points at the left side as follows. E15 lateral acetabular margin of acetabulum, A16 deepest point of the roof the acetabulum or the triradiate cartilage, V17 acetabular teardrop, D18 intersection of femoral head at the postero-inferior acetabular margin, T19 insertion of the hip abductors on the greater trochanter. The distribution also of compressive stresses over the acetabulum, which is usually associated radiographic sclerosis over the acetabular margin, are printed in real time over the screen and thus can be easily and objectively evaluated. Besides that, the app provides data and export for diagrams of load, R, pressure, P, which each can be plotted as a curve allowing easy comparison with normal data and thus help decide the orthopedic surgeon which procedure is objectively indicated. The data are printed over to screen so each case can easily assessed. Save the planned images for later review or consultation. Data are exported as TXT file, ready to print or to input as cells to numbers or Excel ready for chart printing and further research. Based on Tunis' experience with the biomechanical analysis of 460 dysplastic hips in adults, the following simplified general rules for patient selection are: 1. If the load on the hip is increased but the pressure is normal, corrective surgery is unnecessary. 2. If the load is normal but the pressure is increased, an indication exists for pelvic osteotomy. 3. If the load and pressure are increased to an equal degree, such that the pressure and load increases correspond, the pressure can be reduced to normal by normalizing the load. In this case, an intertrochanteric varus osteotomy is sufficient. 4. If the load and pressure are increased, and the percentage pressure increase is greater than the percentage increase in load, a pelvic osteotomy should be performed in conjunction with a proximal femoral osteotomy. 5. Valgus osteotomy is considered necessary to obtain a congruent joint. It must be declared whether or not the resulting load increase can be compensated for by increasing the weight-bearing area of the joint so that the pressure per unit area is diminished.